We're now literally on the last part of the 10-mile race. It's with my great pleasure that I'm going to introduce orthotic Sam Walmsley, who has his own practice. He deals just with orthotics. He taught me something last night which I didn't know, but I'm not going to spoil it because he's going to show that, I think, on his first slide. But he has his own practice in Kingston, and the great thing about Sam, talking to him and his wife last night, is that he works in conjunction with other consultants. It's not just on his own. He works with other consultants, getting advice from them, in order to then make life easier for all the patients that he talks to. All I'm looking at the moment is a lovely picture of his wife on here, actually. Oh, it's gone. You've seen though she's got a canary.
She has, yeah.
Right, Sam, over to you.
Well, I'm shocked, ladies and gentlemen. I didn't think at the beginning of the day I would have something in common with an eminent professor in stem cell research. It's supporting Norwich City, but it's a start. I've been given the onerous task of doing the last slot and talking to you about Gait and Orthotics. I've also got to follow some pretty amazing people, so I hope I do it justice. Let's have a show of hands. Who knows what an orthotic is? That's pretty good. That's good. Well done. Okay. It's an externally applied device designed to alter the neuromuscular skeletal system. So commonly people think it's an insole or something for the foot and ankle, but we put orthotics all over the body when we need to. So what do? They correct or prevent physical deformity. They stabilise a joint or joints. They can reduce pain or symptoms. They can be designed to improve mobility and performance, and they can reduce the risk of injury. I think some of those are quite important, especially in light of what we've been listening today, because a lot of the talk has been about restoring function, trying to improve function to the muscles. But one of the things is, while you're doing that and while you're trying to restore function, you have to try and protect what you've got. So if you restore muscle activity to a muscle, it's not going to function as well if it's tight and contracted. So by wearing orthotic during that rehabilitation time, we can maintain the length of that muscle and make sure it functions more effectively. So what am I? What's an orthotist? We study prosthetics and orthotics at university. There's two universities, one at Strathclyde and one in Salford. Our course has all the usual suspects in there, but we also do a lot on material science and biomechanics. We can work within an NHS department, or we were one of the first kind of areas that were privatised years ago, and we could be subcontracted back into the NHS. It doesn't really work, in my opinion, but there we go. We also have an important role across many departments within the hospital, and especially neurology. So how do we classify an orthotic, and how do we describe to people what we're going to prescribe? Well, they're described by the body segment they act upon. So we have the foot orthotic, pretty basic and straightforward. Then we have something called the supramalleolar orthosis. I simplified these. I tend to simplify things, so it makes it easier for me. Then we have the ankle foot orthosis, or the AFO. These can come in many different designs. This is just an example. You can have a fixed ankle foot orthosis where the hinge does not move, or you can have a hinged, or you can have something out of carbon fibre to give you some resistance and strength. We have something called the silicon ankle foot orthosis, and I thought I'd put this in there because it's something that if you have a dropped foot, is very common for people to ask, or can I have a silicon ankle foot orthosis? Mainly because they're very expensive, but they also can be worn inside normal shoes. It also demonstrates how imaginative us orthotists are in naming our devices. Then we have the knee ankle foot orthosis. It's getting better, and this was a question for the audience. What do you think we call that? Yes, well done, whoever that was. Brilliant. So, how do these things work? What are we looking for them to do? Well, they work using 4 basic principles. 3-point pressure, lever arms, pressure, and the ground reaction force. And I'm going to just briefly touch on those. 3-point pressure is pretty easy to understand. Here we have fractured femur, we have 2 holding forces, and the corrective force is applied to fix the fracture. We've got a case study here of a lady with hyperextension deformity of 30 degrees when she weight bears. She was made a CAFO to control that hyperextension deformity, and you can see the forces that are applied to hold that deformity in place. Lever arms. Now, lever arms are really important to understand because by increasing the lever arm, we can reduce the overall force we have to apply to your body. So we can make things more comfortable, but often people want their orthotic to be as small as possible. So let me explain it. So here we have a device to stop the knee from flexing. And you can see the forces that are applied to the posterior of the leg. If we extend the lever arms, we can reduce the overall forces applied to the posterior leg and make it more comfortable for you. So here's an example of a gentleman with osteoarthritic ankles, the left significantly worse than the right. He was made an AFO, so an ankle foot orthosis up to the back of his knee on the left, because we had to control a large deformity, and he was made an SMO on the right, because the deformity wasn't as large. If we had used the SMO on the left, he would have just broken it. So we needed that longer lever arm to be able to control it. Pressure. There we are. Who can tell me what that means? Yeah, exactly. Yeah. Or pressure is inversely proportional to surface area. Again, very important in making things comfortable and reducing pressure areas, especially when we're dealing with our diabetic patients or someone with neuropathy. This lady had a transtibial amputation on the left side, so her right foot was really important to her, but she had a big ulcer underneath her big toe. So we needed to distribute the weight much better across the base of the foot and reduce the pressure area, particularly on that point. And we did that by using something called a total contact insole. And it's, you get it from the name. It comes into contact with every single part of the foot, distributing the pressure better. And then we have the ground reaction force, which isn't a Jedi mind trick. It kind of is best explained by someone telling me who this is. Newton. Yeah, brilliant. Oh, switched on audience. I thought you'd all be asleep. Okay, so what about his third law?
Reaction.
Yes, okay, smart unicorn, yeah. Okay, yeah. In a kind of modern way, to every action, there is an equal and opposite reaction. And so why am I banging on about physics? Well, it's really important when we look at the ground reaction force and then we start to understand what happens during the gait cycle. The ground reaction force is described as, if I'm standing on the floor, my body weight is applying force to the floor. But because of Newton's third law, there has to be a force from the ground on me as well, and it has to be equal and opposite to my body weight. And that's really important when we come to the gait cycle. The gait cycle is divided into 2 phases, and the ground reaction force applies to the stance phase, and we'll just touch on the swing phase later. So during stance phase, we have it split up into various segments. We have initial contact when heel contact is made with the floor. Then we have a loading response as your body begins to take weight and the musculature supports your body weight. We have mid-stance, which is trying to bring your torso over your foot to propel yourself forward. We have terminal stance when you really are propelling yourself forward off your toe, and then pre-swing just as your toe hits the floor. And the ground reaction force changes in its angle at each point. And why that is important is because you've got joints in your lower leg, and they tend to flex in different directions. So if the ground reaction force passes in front of or behind your knee, it will have an action to cause something called a turning moment. Or in other words, it will tend to flex or extend your knee, or in a lot of cases, cause the knee to snap back or buckle forwards. So understanding where that ground reaction force is, and also controlling it, will help us with our orthotics. But also, when we understand what weaknesses we have in some conditions, we'll have to understand what the ground reaction force is to try and control that leg. When we have swing phase, the swing phase obviously doesn't have a ground reaction force because your leg is in the air, but it's equally susceptible to neuromuscular problems because weaknesses stop you from being able to either pick your foot up or bend your knee properly. thought I'd include this because it kind of shows what goes on in the muscle activity when you're walking. It shows how complicated this movement is and how well your brain copes to control this muscle activity. And also, when we start to look at a condition like transverse myelitis, it explains why things can go wrong with your gait so easily. Again, when I see someone with transverse myelitis or another complicated neurological condition, I again tend to simplify things. So I will try and break it down. Okay, what's happening to is there any motor dysfunction? Or in other words, have we got any spasticity or is there any weakness present? Is there any sensory problems? So have we got any neuropathy or sensory loss? Or is there any problem with the proprioceptive feedback, which is that sensation that people have already talked about today, about where your limb is in space, and it helps with balance. And then we have another area which I look at, which is alignment. Do we have any issues with alignment? Any bony structural problems? Any instabilities around the knee because ligaments are not functioning properly? Or maybe that we have a tightness in some muscles because of a long-standing contraction. And how that then affects your foot posture. And posture doesn't just mean your standing posture, but also means your foot posture or knee posture. So we have some examples, and I want to talk about each of those individually. So first of all, we're looking at spasticity. This lady has a spastic foot drop causing initial contact to be made with the forefoot, which is the kind of start of her bad gait pattern really. At that point, then it causes the knee to snap back into hyperextension. You can see it just there. And now, in itself, that's, you know, she copes with it, she can walk. But if you imagine, if that happens in the longer term, for the rest of her life, she's going to end up like our 72-year-old lady with the 30 degrees of hyperextension of the knee, because you're continually going to stretch those posterior aspects of the knee joint. She also has compensatory movements, so she has to flex her hip and flex her knee more to be able to bring her leg through, and so she doesn't trip on her toe. So what are we looking to do? We need to prevent those movements that we're talking about, and we wanted to do that by making her something called a hinged AFO. So we wanted to stop the initial contact with the forefoot and get her to achieve a heel strike. We wanted to stop the hyperextension at the knee. We wanted to also, improve her symmetry of her gait. And then you have her walking with the AFO, and you can see she's not got hyperextension. She's got a nice, almost like loading response because she's starting her gait cycle properly. She's starting with good heel contact and then rolling through into a nice toe-off position. She's getting good symmetry, her step lengths are the same, she's not having to flex and extend her knee excessively, so she's not using unnecessary energy. So she can walk for longer, she can walk for faster. Okay, let's move on to weakness. This presents a different set of problems. This young man had weakness at his hip, his knee and his ankle. He had something called flaccid foot drop, which is when the foot just falls uncontrollably. There wasn't any real tonal involvement. He also had something called a Trendelenburg gait, which I'll point out in a second. He had valgus at his ankles, so his ankles were tipping in, so he had poor stability around his ankle joints, which meant that he had very poor balance and proprioception. And you can see he walks with knee flexion, quite a sort of almost like a lazy walk. His foot, he makes initial contact with his forefoot again. And this Trendelenburg gait pattern is quite interesting because it means that he has weakness around his hip. And you can see as he walks, his pelvis drops to one side, so it's more difficult for him to then clear his leg through and achieve toe clearance when he's walking. So, what we wanted to do here was a little bit different to the spasticity case because he's weak and he's actually got a degenerative condition. So we wanted to control some of this movement pattern that he's developed, but we also didn't want to control it too much, so he just became reliant upon the orthotic and then allowed the weakness to get worse. So we made him something that was a little bit more flexible and a bit more dynamic. So the ankle foot orthosis we provided with him was a carbon fibre one that sprung at the ankle joint. We also made him something called a neurological insole, which improved his proprioceptive feedback by really stabilising his foot and ankle and giving him as much information from the floor as possible. And now you can see him walking. So he's getting a bit more knee extension as he's walking. He's getting heel strike. And all those movement patterns are good, but what we haven't been able to do, we haven't been able to affect his Trendelenburg gait pattern, because this is a weakness at his hip. So, that's when I get on the phone to Fashida and say, Fashida, I've got a problem here, and they go and see. In fact, I think she was in our clinic, happened to be in our clinic when that happened. So, and then she works on him, improving his core stability and his pelvic stability. Next we have proprioception. This is an interesting case because he's got an acquired brain injury, but he's actually got active movement, so he can voluntarily move his muscles and his joints. But it's ataxic, so he hasn't really got control, and when he tries harder to control it, he loses more control of that limb. And this is really because he's so proprioceptively poor, he's getting no information from his feet. So we wanted to improve that, and for this chap we just used, again, a neurological insult. Now you can see and compare, so all we're doing is stabilising his foot, and you can see his heel strike's a little bit better. He's not dragging that toe through as he's doing on the left side. It's coming through in a cleaner. He's also standing in a straighter alignment, and the left foot doesn't drift off to the side. So, and this is just by a simple insole in the shoe. So, and then the other important point, there's loads more to do there really, but as an orthotist, you have to kind of hand over to your other healthcare professionals, because this is where they need to then work on his muscle control, his core stability, to take him on to the next level. It's one of our VIPs. She came to see me, well, she didn't come to see me, I kind of coaxed her into being treated, and we wanted to see if we could improve this knee alignment and improve her general posture. It's long-standing kind of standing posture that we were trying to improve, and Fashida was also working with her again to improve her core stability and improve her pelvic alignment. So you can see here how the knee falls into a valgus position, and we want to limit that because unfortunately that knee is only going in one direction unless we do something about it. So there we are. So you can see that on the right side we've got her standing in a pair of insoles and footwear, but the footwear has also been raised. So we detected that there was a slight leg length discrepancy, and that was meant because there was a leg length discrepancy on the right, it meant that she was flexing her left knee as well to bring her pelvis into a level position. And then there was an instability around the ankle, so the knee was falling in as well. So we corrected the leg length discrepancy, and then automatically she was able to stand up a little bit straighter because she didn't need to bend her left knee. And on top of that, we also corrected some of the forces occurring at the foot and ankle to push the knee into a better position. So you can see that the angle of her knee is improved on the left side. And you can also see here, from the sagittal plane, from the side, that we've improved her standing position. Again, this is kind of right at the beginning of the rehabilitation here. There's a long way to go, but this is just the first stage. I included this because it shows what happens. On the left side, you can see that left knee, if you can see that. I wonder if we just switch the lights off. On the left side, you can really see that knee falling into a valgus position, and that deforming force that constantly happens as she's walking. Come on, Sally, hurry up. There we go, just there. Okay, so that is constantly happening on that knee joint, and it's not good for it. So we want to try and reduce that, and we could come above the knee, we could make a whole cathode, but then we're going to affect her mobility too much, so that's just not going to be functional for her. So we've used an insole to try and reduce those forces as much as possible. Finally, we've got another star of the show. Again, this is when it gets complicated, when you have sort of mixed patterns occurring. We've got sort of an asymmetrical pattern of weakness. So one leg falls out to the side, while the other leg falls to the inside. We get compensation through other musculature. We get tightness in the calf, causing restrictions in movement, meaning that we can't correct the foot into a neutral or functional position. Also, on top of all that, we have something called neuropathy. So she hasn't got sensation. She can't tell us whether something's hurting. And because of that, we got a nasty sore on her foot and ankle after we tried a little bit too hard to push her into a corrected position. And this happens so quickly. So we had to rethink what we were doing, and we needed to offload that prominent area on the inside of our ankle that became sore. We needed to increase the angle of the left AFO to accommodate for the tightness. So here you can see a raise on the left AFO, but when you raise underneath one leg, you also have to raise underneath the other leg. So we had a compensatory raise on the right leg to bring and make sure her pelvis was in a more symmetrical position. And that's the after walking, so much more stable, getting a nice heel strike. The deforming forces on the foot and ankle have been removed, so we're protecting those joints. This is where she taught me who was in charge and did a little sit to stand, just to show the hinges working on the ankle joints. I'm going to have to pay her image rights, I think. She's okay. So, as with most people have been talking about what's sort of the future of orthotics. Well, I could say there's two sort of really interesting areas for TM. There's something called dynamic light garments, which I don't think has been mentioned today at all. And this is a system where we apply compression to the body, which improves proprioception. It's been used with children for some time, and it's been used in Parkinson's disease. But what we're trying to maybe achieve is, by compressing the limb or the joint or the whole body in some areas, we can improve stability, we can improve your awareness of where your foot is in, or your body is in space, and therefore you can get more control over your limbs. They can also, there are also some interesting applications by applying pre-stressed elastic panels to these, so we can actually almost mimic muscle movement. So we can pick the foot up with an elastic panel within a lycra garment. So there's some quite interesting developments with the lycra garments. And again, I thought I'd include this, since everyone else has, and it seems to be the buzzword of the day. But FES, I think there's huge kind of scope for a amalgamation of FES and orthotics, be that in the therapy side or within the functional side. I'd really like to kind of put some heads together with people that are here and maybe develop some bespoke type of orthotic FES system that we could then really tailor-make to people's individual needs. So if you have a instability that cannot be controlled through your own musculature, say your knee collapsed into valgus because you've torn a tendon or a ligament, then maybe we can stabilise that with the orthotic, but then use the FES to give you your functional movement. That's it. I'd like to end by saying it's a huge privilege for me to be able to share this stage with some pretty amazing people and lecturers. And also a big thank you for the guys who've organised this, because I've learned an amazing amount today. And it's only with events like this that we can all learn and improve our knowledge. And if ever we needed reasons for doing that, it's because the next generation of clinicians are just waiting in the wings to take our place. There's one more thing. I've wanted to do this for years, and what a better day. Is the professor here? Norwich City 6, Scunthorpe United 0. I didn't check the results, sorry. Yeah, give you a full breakdown.
You thought he was giving you a lecture. He was actually on here looking up and on the web to see what the score was. Sam, thank you very much. I think it is absolutely remarkable what you're able to achieve. In fact, I think everybody today has shown a huge way in which they're able to contribute to the problems and the challenges that are put in front of them. And I think when you see the before and afters, and particularly when we've got some people here who've actually been subjected to this treatment, it's quite incredible. Are there any questions? We've got our other FES people here as well, if you'd like to ask them. Let's over by the window there.
Hello. Are we on?
Yes you are, yeah.
I've got dropped foot.
Yeah.
And I've tried all sorts of things, and perhaps I haven't tried them for long enough and well enough. But one of the things I have discovered is that if I walk on sand at a certain texture, and I found places where there's sand. I come from Western Supermare.
It's not Barbados or something.
No, no. The sand there is ideal.
Yeah.
It's muddy sand.
Yeah.
But I can almost walk normally on certain densities of sand where I can't on a hard surface. Is there a device in your collection, or is it not possible to make a device that has a certain give in the density of it, so that you'd have exactly that effect, that your heel would go down into it and give you the normal heel strike first?
Well, I normally say yes to people straight away, because, you know, orthotics generally are bespoke devices. So there are a huge number of materials out there with every single type of density. We can go from, you know, rock solid density to very, very soft silicons or gels. And then we could make a moulded insole to the base, like the sand forms around your foot as you're stepping. So yeah, there is a possibility. It's always difficult when someone goes, well, I've tried orthotics, and it's like saying, you know, you've tried a physio until you've met fascio. They're two different things. So it really depends on the style, the make, whether the orthotist has the facilities to adjust and to fine-tune the orthotics on site, which is essential. A lot of people go to a orthotic clinic and they say, okay, great, I'll just adjust it, it'll be 2 weeks and I'll be back here. And that's no good. You need to be able to adjust it on site with the patient there. So yeah, I would say that it's certainly worth experimenting. And the other nice thing with orthotics is there's no real side effects to them. You put them on and you see if it works, and you kind of walk up and down and tell me whether you want it a little bit softer or a little bit harder, whether you want a bit more give in the material or not. It's as simple as that.
Thank you. Any other questions? Yes, one here.
I'm a C70T2 and I was a quadriplegic, and after 6 years of doing my own physiotherapy, I've actually decided to take off my AFO because I've got a foot drop on the right hand side. One, because it was excruciatingly painful, about 8 or 9 different AFOs. I had a brilliant orthotic who tried to help me. I'm now doing Tai Chi and Pilates, blah blah blah, and you've got to have them off, you can't have them on. But apart from the excruciating pain, when I did take it off at home, my leg was so weak I kept falling over again. But I just saw my spinal injury expert about last month, and he said, well, stop falling over and put it back on. Put your orthotic shoes back on as well. And I said, well, no, I can't, because my walking's going to deteriorate again. And I've worked so hard on my Pilates and my Tai Chi to get it there. And when I do Pilates for like about a long weekend or go away on like workshops, my walking so greatly improves.
I think I had this conversation with someone earlier about, you know, when you use an orthotic and then you become used to that orthotic, and do you become reliant on it? The conversation I had was, you know, my orthosis I know it's stopped me from twisting my ankle, but when I take it off, I then feel like I've become reliant upon it. Well, we can't really change that. All I normally say to my patients is you need to supplement. It's not just an orthotic treatment. You need to supplement it with your physiotherapy, with Tai Chi. It's okay to do that work outside of your orthosis. Sometimes we use orthotics just for therapy, so only for walking, to try and stretch out a muscle. I would also say that you need to be clear when you're assessing whether you take the orthotics off. Are you doing any damage? Not when you step on your foot, is your foot going to snap. Are you doing any damage in the long term? Is there going to be any alignment shifts in your ankle joint that are going to be difficult to get back the other way? Is your foot going to fall into balance? Is your TA tightening because your foot's not in the right position? There's some basic examples of where you can see long-term problems manifesting themselves in the future. So I think, whereas, you know, if you're more functional without them, maybe there's a place for the orthotics with part of your therapy to try and maintain the length of your tendons or your foot position. And also, it's difficult for me to comment on a situation when an orthotic's painful. I do believe that orthotics should not be painful. So a lot of, you know, people are told that, oh, well, they just expect them to be painful and you'll get used to them. I think that's wrong. I think there's a degree of getting used to anything when you put it on a new pair of shoes. You know, you need to wear them in slightly, but it's different. An orthotic, and your orthotist should work to make something comfortable.
Any more questions? Yes, one. Wait a minute, hold on.
Our little girl has to wear AFO, she's 8, and she's only been injured for a year, and she goes to school and she wants to wear dresses and skirts, and we're just about to have a big summer holiday.
Yeah.
We don't want her to not wear them for 2 weeks, because we've noticed how much improvement she's had by wearing them. And they look awful on her with the skirt on. Is there anything she could have that's not up to here with a big old strap around it? Could she?
Maybe the Sappho might be appropriate. They do a child's Sappho. Again, it would depend on her range of movement and also the amount of weakness that she had around her knee, because the knee snapped back into hyperextension. And there are some kind of elasticated supports that might work. And the Sappho can be skin matched, so you can get it in 8 different colours to match her skin colour. It won't tan with her while you're on holiday, unfortunately, but
She wears high factor, don't worry.
Okay. But I also have to say that it's with children, I take a kind of a bit of a hard line and say that the more they get used to the idea that they're going to wear orthotics, the less of a fight we'll have in the future. I have some parents who'll say, well, let's just make it the same colour as their school socks so that people can't see it. And if that attitude filters down to the child, they will not want to wear it. I've had that experience so many times. Whereas if you make it bright colours and you just acknowledge the fact that they've got to wear a splint and it's a fact of life, then it tends to be accepted better later on in life.
Thank you.